Very good morning, ladies and gentlemen, and welcome to yet another very important Shri webinar program organized by Shri Academy. So, before going to this important notice today and the lecture today, let me remind you some of the housekeeping agendas. We all know that the today's session will be closed for entrance from 9:50 a.m. to join in, and no late attendees will be entertained after 9:50 a.m. Each attendee should have been attended till the end of the webinar to obtain the certificates and 1.5 CPD points to collected, because that the Shri webinar series is strictly adhered to the NCCPD guidelines. And this is very important to keep your microphone shut, and we will be giving you a chance to ask questions through the chat option throughout the webinar as well as at the end. So let us move on to the lecture today. Just prior to that, I would want to remind you, after finishing this webinar, there will be a special place where you have to fill the form so we can send you the CPD pointed certificate through email. And that option will be closed by 11 a.m. So do not rush out from the lecture after the lecture is finished, after Professor has answered all the questions. We want you to remind you to fill the form as well, the Google form actually as well, and join with us so we can send you the email with the certificate of yours. So without a further ado, let us move on to today's topic. It's my real distinct pleasure to introduce you the guest speaker for today's very special lecture from Sri, renowned figure in the field of internal medicine, a senior professor Arjuna de Silva, the senior professor of medicine at the University of Calaria. He has maintained and he has done many contributions to the medical sciences, particularly in liver diseases as well as clinical practice, also in research areas. His excellent knowledge and exclusive knowledge and groundbreaking work has earned him distinguished reputation not only locally but also internationally. So, without a further ado, I would like to invite Vidya Jyothi, Senior Professor Arjuna de Silva. Sir, the floor is yours to conduct this very important lecture on Fibroscan, the stethoscope of the hepatologist. Sir, the floor is yours.
Thank you, Sahan, and good morning, everyone. Okay, so I'll start off with a case long time ago in a galaxy far, far away. In 1992, mistakes, a 55-year-old man underwent a liver biopsy for suspected cirrhosis. The patient complained of right hypochondrial pain and tachycardia, and a surgical opinion was obtained. However, unfortunately, the patient had a cardiac arrest before being taken to theater and passed away. Fast forward that to 2024, Mr. Y, a 40-year-old man, previously well, submitted himself for a routine medical checkup, who was then referred by his GP with fatty liver grade 2 on ultrasound scan of the abdomen. So remember that all that glitters is not gold. For 140 years, liver biopsy has remained the gold standard. However, the mortality, as illustrated by the previous case, liver biopsy is 1 in 10,000. And though that's a relatively very small number, for that individual it happens, it's a disastrous thing, because previously this patient was fine. So if we go for, we need for non-invasive tests is very important. And currently there are a plethora of non-invasive tests. So the non-invasive tests, important to differentiate. You have radiological tests, which are vibration controlled transient elastography or VTEC. Fibroscan is the commonest of that. Acoustic radiation force impulse or RAFI, which can be divided into point shear wave elastography or two-dimensional shear wave elastography. There is also MRI elastography, which is becoming the new gold standard. There are also blood-based tests. For instance, FIB4 is the commonest and easiest to do. There is enhanced liver fibrosis test or ELF, and there is Fibroscan, AST score, FAST for short. There are many tests like this. So we used to call this NAFL, but now the nomenclature has changed and it's now called MASL, metabolic dysfunction associated steatotic liver disease. So NAFL is no longer called NAFL, it's called MASL. So this is a global phenomenon. 25% of the population has MASL. In Asia, it's 31%. South Asia, 34%. Sri Lanka, our own study, 32.6%. And 51% of obese patients have MASL. 22% have diabetes. And if you flip it, you take 62% of type 2 diabetes have MASL. So something new about liver disease. This is the new classification of steatotic liver disease. So it's diagnosed either commonly on ultrasound, but it could be diagnosed on biopsy as well. As I said, we do less and less biopsies. And if you have 1 out of 5 metabolic risk factors, it's called MASL. NASH was now called MASH, metabolic dysfunction associated steatohepatitis. If there is an increased alcohol consumption, we know that there is no safe limit for alcohol now, but if there is increased alcohol consumption, it is called METALD, metabolic associated alcoholic liver disease. If it is more than 420 grams per week, then it goes on to alcohol associated liver disease or ALD. And then there's specific etiology associated liver disease like drug-induced Wilson's. And then there is again another category called cryptogenic. So this is the classification of steatotic liver disease. I will just run through the adult criteria. BMI more than 25, fasting glucose more than 100, blood pressure more than 130/85, triglyceride more than 150, and LDL less than 40 on treatment. So this is what the Fibroscan looks like. Fibroscan is a trade name for VTech. There are different machines as well, but this is the common thing in the guidelines. So if you take this measures the fat in the liver, which is called CAP, and it measures the liver stiffness. It also you can measure splenic stiffness, which we'll talk about later. It's the same machine you use, but ideally you can use the same probe, but ideally we use another probe. How and why? Anyone can do it with simple training. Abroad, it's mainly nurse technicians who do it. Interpretation is the important thing that you will need a hepatologist there. Fasting for more than 4 hours. Try to palpate the liver first. Always be clinical. Mid-axillary line, xiphoid, the two that connect, that's the best point. BMI less than 30, you use the M probe. More than 30, you use an XL separate probe. Children have ideally another probe, called S2. Relative contraindication, there is no absolute contraindication. BMI more than 40, ascites, pregnancy, hepatitis. Metrics more than 10% valid, success rate should be more than 60%, and IQR should be less than 30. Then only you can consider the report valid. The devil is in the detail. Fibrosis scoring system of Bavino 7. This is the latest thing. It's a bit of a busy slide, but it will help us understand the research we've done. So on the left side, I have got the normal histology. There are 2 scoring systems, Ishak and Metavia. Metavia is what we use. So you have F0, no fibrosis. F1 is again not very significant. F2 to F4 is significant fibrosis. F4 is cirrhosis. So, what does this Bavino classification say? It's very easy to remember. It's a rule of 5. Less than 5 is normal, 10, 15, 20, 25. If you have liver stiffness of more than 25, you have established cirrhosis with clinically significant portal hypertension. Very easy to remember. Only thing that complicates it a bit between 10 and 5. So 5 is absolutely no problem. 8 is another cutoff point that's important. So 8, if it's below 8, we consider there is no significant fibrosis and we can exclude that. So between 8 and 10 is F2 fibrosis on the Metavia score. Then more than 15 is F4. And that means there is another concept called, we used to call about compensated liver disease. Now this is called compensated advanced chronic liver disease or CACLD. So CACLD is diagnosed on this. And again, if the platelet count is, if the fibrosis level is below 25, then you can either bring in this splenic stiffness or platelet count to see whether there is varices. Because as I said, more than 25, you have clinically significant portal hypertension and varices. And why that is important is because you need to start the patient on carvedilol, which is a non-selective or selective beta blocker. So that's important because management changed. So this is the newest guidelines, which is amalgamation of the Endocrine Society, the Obesity Society, and the Liver Society. So if you have type 2 diabetes or the metabolic risk factors we discussed before, you do a FIB4. So FIB4 is very simple. It's an app you can download. It involves only the AST, ALT, patient's age, and the platelet count. So that's available in any hospital in Sri Lanka. You can then calculate if the FIB4 is less than 1.3, you can forget about the patient and reassess later. If the FIB4 is more than 1.3, then you, and less than 2.67, then you have to investigate that patient further. You can do a Fibroscan. If it is more than 2.67, you can straight away go to hepatology referral because most likely that patients will have cirrhosis, which you can pick up on a normal ultrasound. Right? So very simple. That's how you go. Less than 1.3 or more than 1.3. FIB4. So now we'll discuss 7 studies which we have done using Fibroscan in Sri Lanka and we published in international journals. So the first one we did was splenic stiffness measurement combined with liver stiffness measurement. Bavino criteria predicting the presence of esophageal and gastric fundal varices in compensated advanced chronic liver disease. So measurement of liver stiffness using vibration control elastography is being increasingly used as a screening tool to predict varices. Why? Because endoscopy, the other way of seeing varices, is invasive, it's costly, and it's difficult to organize. Our aim was to test the utility of Bavino's 7 criteria and other combinations of liver stiffness, platelet count, and splenic stiffness measurement to predict the presence of varices in a cohort of Sri Lankan patients with CACLD. So methodology, prospective recruited participants, 174, child A cirrhotics with a low BMI, were recruited from the Colombo North Teaching Hospital. Exclusion criteria were active alcohol or drug abuse, HCC or hepatocellular carcinoma, extrahepatic obstruction, and any other cause of portal hypertension. So LSSM and SSM, which liver stiffness and splenic stiffness, were measured using Cosson's Fibroscan by a single operator, more than 1,000 cases. And he was unaware of the endoscopic finding. Varices were assessed independently by a blinded operator. Sensitivity, specificity, and a negative predictive value and accuracy were calculated. So here you get the patient characteristics. Age 61, mainly males. Etiology was mainly alcohol, but you had nasal and cryptogenic as well. BMI was 25, I told you. Portal hypertension parameters, platelet count 130, varices in 61%, esophageal 11% had gastric varices, and average liver stiffness is 23. What about sensitivity and specificity of Bavino criteria? So on the left side, we have the Bavino criteria, and right side, we have splenic stiffness more than 30, and combination of splenic stiffness and liver stiffness. So here we find sensitivity is 61%, specificity is 79 as compared to 74 and 82%. So even the accuracy was higher. So in conclusion, Bavino 7 criteria had a low sensitivity but high specificity to predict esophageal cardiofungal varices. However, splenic stiffness more than 30 alone or combination of liver stiffness and splenic stiffness more than 15 seem to predict esophageal varices better than the traditional 7 criteria. So that was what we found. So second study was predictive value of FAST, and that is Fibroscan ESD, and modified FAST, which is incorporating splenic stiffness, compared to Bavino 7 criteria, rule out esophageal fungal varices again in CACLD patients. So FAST score again is a combination of Fibroscan parameters, LSM and CAP. CAP means stands for controlled attenuated parameter, or the fat level in the liver. You are measuring the fat in the liver. AST or aspartate aminotransferase has shown good accuracy by identifying high-risk patients with MASH, because normally MASH is a histological diagnosis. We aim to compare FAST and mFAST scores incorporating splenic stiffness measurement compared with Bavino 7 criteria, rule out the presence of esophageal cardiofungal varices, the cohort of patients with CACLD. So consecutive patients with newly diagnosed child CACLD, non-viral, BMI less than 30, outpatients were recruited. They underwent upper GI endoscopy, and these parameters were calculated. We used again Fibroscan. FAST and mFAST were calculated. Area under the receive operating characteristics or AUROC was calculated for both scores. Sensitivity, specificity, positive predictive value, negative predictive value, and accuracy were calculated. And the best cutoffs for the presence of clinically significant portal hypertension were calculated. So 147 patients were recruited, mean age was 61. Most of them were males, 91%, 91. 89% had either esophageal or cardiofungal varices. AUROC for FAST and mFAST for 0.71 and 0.8 respectively. FAST scores less than 0.5 and 0.57 had a specificity of 89 and 81, and mFAST were scores are less than 4.8 and 0.65 had a specificity of 89 and 80 were taken as cutoffs for ruling out varices. So that was the level. So here you have Bavino criteria on the right side and FAST scores on the left. So here, unfortunately, the specificity is high, but sensitivity is only 42% as compared to Bavino's criteria, which is higher, 87%. So here, in conclusion, Bavino's 7 criteria performed better than FAST and mFAST scores in ruling out portal hypertension and varices in this cohort of non-viral, non-obese patients with CACLD that was in our cohort. So then our third study we went on to do was we tried to develop a smartphone application to exclude esophageal cardiofungal varices in a cohort of patients using AST levels and liver stiffness and splenic stiffness. So we used AST-ALT ratio, liver stiffness measurement, splenic stiffness measurement by transient elastography to develop a statistical model and present it as a user-friendly smartphone application to exclude the presence of esophageal cardiofranal varices to avoid upper gastrointestinal endoscopy in selected patients. So this was a prospective study carried out among patients with child's class A, non-viral, again BMI less than 30, LSM and SSM were obtained using Fibroscan touch by a single operator blinded to the presence of varices. Predictors used to develop a formula were, as you said, ALT, liver stiffness and splenic stiffness. Multiple logistic regression was used to create algorithms. 70% of the sample validated using 30% of the sample, bootstrapping, which is a technical term, to 1,000. I will explain that in the next diagram. Best algorithms with the highest area under the curve were selected and identified cutoff values. Cutoff values used to predict the presence of varices. Values included in the smartphone application of Android and iOS-based platforms. So 109 out of the 211 had varices. After modeling different combinations, logistic regression formula was 5.5 LSM, SSM, ARR, result in an area under the curve of 9.3. Cutoff values of less than minus 1.25 predict the inclusion of varices with a negative predict value of 90%. Cutoff of more than 0.827 had a LRF predicted the presence of varices with a positive predict value of 91%. And this was used to develop smartphone upon the Angular 2 platform. So that may be a little hard to understand. So we will show this in a visual abstract. So we had a sample of 211 training group that we divided the group into varices present, varices absent by Fibroscan and endoscopy confirmed, did multiple logistic regression and developed the algorithm, cutoff points and ROC identified, applied that. So you derive it from one population. That's the principles of statistics. You can't test it on the same population. You must validate it on a separate population. But since our population was small, we used a statistical thing to boost the sample size from the 30% to 100, 1,000. Then predictive accuracies were identified and we developed the smartphone app. This is what the app looks like. Prediction, you feed in the data and you get the value. The new formula using AST-ALT ratio, liver stiffness measurement and splenic stiffness can be used to predict the exclusion of varices with a high accuracy in non-obese patients with compensated cirrhosis of viral etiology. Smartphone application derived from this model is easy to use as we showed, and this is the first mobile application to be used to exclude or predict varices using splenic stiffness. So a fourth study was now, we went on to see the association between steatosis and liver damage in transfusion-dependent beta thalassemia patients. So MASL is a global health problem. Iron is a leading cause of liver damage in patients with transfusion-dependent thalassemia. We want to evaluate the contribution of MASL to this liver damage. So 45 heavily transfused TDT patients who did not have ultrasound evidence of cirrhosis were evaluated for effects of iron overload, including the presence of diabetes, hypogonadism. Serum ferritin was measured using MRI elastography and liver Fibroscan. Liver enzymes, AST and ALT were calculated. Liver fibers and steatosis was measured using transient elastography. So what were the results? 9 or 20% had significant steatosis. Their body mass index was liver fibrosis scores in patients without significant steatosis was p-value was 0.03 and 0.004 respectively. On regression analysis, control attenuation parameter, the fat in the liver was associated only with increasing BMI. So that's obviously the BMI increases, the fat in the liver also increases. Transient elastography scores, degree of liver fibrosis was associated with increasing age, CAP score, male gender, and the presence of diabetes. Neither liver steatosis or fibrosis showed significant association with liver iron concentration. That's important. Or the iron-related organ damage, hypogonadism. So this is the values again. If you look at the p-values, so age, CAP, diabetes, those are the significant p-values there. So, in conclusion, to summarize, this is a very crucial study because we found that in these patients, in transfusion-dependent patients, the steatosis or the fat in the liver seems to be more important than the iron in the liver damage. So, this is a new finding, and so it's a very important point. So, we went on to assess the reversibility of liver fibrosis in patients with transfusion dependence. This is the follow-up study of this beta thalassemia following intensive chelation. So here we aim to evaluate the reversibility of liver fibrosis with intensive chelation therapy in transfusion-dependent patients. So we prospectively followed up a section cohort of TDT patients intensive chelation for 2.5 years to assess the reversibility of liver fibrosis. The liver fibrosis and steatosis CAP score we measured by transient elastography. LIC was assessed by Fibroscan. That is them using MRI program to measure the liver, the iron in the liver. Desferrioxamine was used, or deferasirox, which is the oral tablet, was used to remove iron. Compliance in the above chelators was assessed using a brief medication questionnaire, a tool developed by Vidya. Data was analyzed using analyzed with R programming language. So gender variability of fibrosis and fibrosis reversibility. Here we have the patient's frequency, so not reversed and reversible. Total of 45 patients, 22 are males. 80% of the patients liver iron decreased. 51% fibrosis reversed with intensive chelations. That's also important. Fibrosis can be reversed. Remember that. So it can be reversed by drugs. It can be reversed by diet. So good compliance was divided into good compliance, moderate compliance, and poor compliance. Again, here the parameters. So what stood up again was the CAP and the first point. Fibrosis is reversible. Liver fibrosis was significantly elevated in TDT patients with poor drug compliance. That's obvious. CAP, age, and drug compliance are independent predictors of liver fibrosis reduction. LIC by Fibroscan was not an independent predictor of liver fibrosis reduction. So that's shocking. We always thought that because iron was toxic. The liver, it is toxic, but if you compare with fat, that is more toxic. So then we went on to our fifth or sixth study, which we were studying the effects of probiotics on clinical and biochemical and radiological parameters in obese children with MASH measured in combination with dietary and lifestyle modifications. So childhood obesity is a global problem again with associated with metabolic abnormalities. Sri Lanka has both malnutrition and obesity. So the global prevalence varies from 3% in non-obese children to 80% among obese children. of MESL. In Sri Lanka, the prevalence of MESL in a suburban community was 8.4%. Gut liver axis is thought to play a major role in the pathogenesis. Probiotics are known to alter, sorry, probiotics are known to alter the gut microbiota and therefore could be a therapeutic option in the management of childhood obesity. These children with MESL MASH. Obese children were treated with a nutrition clinic, University of Colombo Pediatric Hospital, LRH, were recruited. Anthropometry, body fat, and metabolic derangement, liver ultrasound scan results were evaluated baseline. Transient illustrative fibroscan was performed on some sample of these patients. 84 patients were recruited and randomized in the probiotic and placebo groups, so 43 and 41. Mean age was 11.3 versus 12.1 in years in probiotic and placebo groups, so they were similar. Baseline parameters included liver disease stage on ultrasound scan, body fat percentage, fasting sugar, lipid profile, liver function. C-reactive protein did not show any significant intergroup difference. What about the results? So in the probiotic group, a statistically significant reduction in body mass index was noted from the baseline value. However, the reduction was not significant compared to the placebo group. So there was a reduction, but when you compare it with the placebo group, it was not statistically significant. There was significant reduction in triglyceride aspartate AST-ALT ratio and alkaline phosphatase in the placebo group over the treatment period. Although the liver disease stage in ultrasound improved stage 2 to stage from stage 3 to 2, in small number of patients in the probiotic treated group, transient elastography did not demonstrate significant improvement. So our results indicate that probiotics have no advantage over lifestyle modification for improving obesity associated metabolic derangement in children. So there is a caveat here that the important thing is when you're talking about probiotics, it's a very heterogeneous group. It depends on the type of probiotics, the dose of probiotics. You need more than 10 billion colony forming units. So it's a very difficult thing to homogenize. So that's the important point when you talk about probiotics, but if you take it in general, there is no association benefit. So a final study, we all have learned about Gilbert syndrome in physiology. The presence of Gilbert syndrome protective in patients with metabolic dysfunction is dysfunction associated steatotic liver disease or MESL. So that's a question we want to find out. So we know that Gilbert syndrome is a prevalent genetic disorder known for high bilirubin, that is indirect bilirubin in the blood. Although typically harmless and symptom-free, this condition has been linked to various liver-related issues because of its impact on bilirubin metabolism. The escalating prevalence of MESL is now a major global health issue, with recent research suggesting a possible association between Gilbert syndrome and diverse liver disease. These connections should be attributed to the antioxidant characteristics of unconjugated bilirubin. What about the aims and methods to investigate whether the presence of Gilbert syndrome influences the prognosis of patients diagnosed with MESL? We did a retrospective cohort study was conducted at Navalok Hospital in Colombo. 2 accurate measurements were implemented to require relevant anthropometric, biochemical, and social demographic parameters. Liver fibrosis was assessed using the Fibroscan 502 touch, performed by a single operator with more than 1,000 test experience. Data collection was then analyzed using SPSS 28. What were the results among 111 patients? 22.5 exhibited high bilirubin levels, that is above 1, and 77.4 had low bilirubin levels. Patients with high, that is, patients with Gilbert, showed an average liver stiffness of 10.19 kilopascals, whereas those with low bilirubin levels had an average stiffness of 10.44. In the high bilirubin group, 16% had liver stiffness exceeding 15 kilopascals and 12% had liver stiffness surpassing 20 kilopascals. Conversely, in the low bilirubin group, 18% had liver stiffness over 15 and 9.3 had liver stiffness more than 20. So in conclusion, in a limited cohort, so this is a small sample, Gilbert's presence of Gilbert syndrome did not seem to adversely affect muscle patients. However, definitely larger studies are needed to confirm this finding. So that's an interesting thing. Ergo consisto means Cicero was a famous Roman senator. He said, these were his last words, so I go no further. That's what it means in Latin. So, to summarize this, liver stiffness and sphenics, we had 7 studies done. Out of the 7 studies, there are some important points which are take home, which is evidence-based, and some, of course, may need more evidence. So liver stiffness and sphenic stiffness combined is better than this Bavino 7 criteria for the presence of varices. That is limited to our cohort. We can't generalize that. We have developed a smartphone app to help predict the presence of varices. And Bavino 7 criteria performed better than FAST and IMFAST scores, ruling out varices in non-obese patients. So this is very important principle, proof of concept, right? Steatosis may be more toxic to the liver than iron in thalassaemic patients who are transfusion dependent. So that's a novel finding. We need to go forward. The other question is LSM seems to assess fibrosis reversal. So that's a good thing to measure. In the past, we had to do liver biopsies to measure fibrosis. But here now we can do liver stiffness. Then probiotics are not helping the treatment of obese children. And Gilbert seems to have no obvious effect on muscle patients. However, as is a small sample, we are expanding this study and we'll be able to give you a proper study soon. So these are the people who are involved in this study, which I have to thank all these people. And this is when you ask ChatGPT how liver imaging will be done in 25 years, this is what the answer they come up with, something like this. So this is AI generated picture. So the future of liver scanning is obviously liver medicine is obviously going to be non-invasive, right? To get better and better. So here, I mean, there are a lot of research stuff here, but as I said before, the important message here is that first, that the nomenclature has changed. Now we don't say NAFL, we say MESL. And steatotic liver disease classification is new. You should know that. And then Fibroscan is an essential part of a workup of the liver. So unfortunately, we have only 2 Fibroscans in the country. One is in the private sector and one is in RAG. So we definitely need more Fibroscan. So can you use other methods of this thing? Yes, you can. But you have to just check the cutoff values for that. So you can use, I told, even two-wave elastography, normal ultrasound, you can have software to measure liver stiffness. So that is not ideal, but it is still workable and it's better than nothing. So again, Fib4 score, especially in diabetics. Diabetics are the crucial group. Fib4 score very simple. We have all those data. Any hospital, any even a peripheral unit can do the full blood count to get the platelet count, AST, ALT, and the patient's age. Then you have a downloadable app and you can calculate the FIB4. If it is below 1.3, very unlikely this patient is having advanced liver cell disease. Nothing to worry. You can just follow up the patient. The patient has more than 1.3, right? You can, because there is enough evidence to show that non-selective beta blockers like carvedilol, propranolol is also used, but trials have shown that carvedilol is better. If you use carvedilol, it can prevent the progression of cirrhosis, help reduce the progression of cirrhosis, and prevent bleeds. So, if there are varices, you have to start on carvedilol. That's another important basic thing. So, to start on carvedilol, in those days, the only way we knew there were varices were unless we had to do endoscopy to confirm. Now you don't need to do that. If the elasticity score is more than 25, you can simply start the patient on carvedilol if there is no contraindication. So that's another important point. So starting carvedilol early without non-invasive. So otherwise, if it is below 25, then you have to consider the platelet count as well. So that is how it goes. So that is the summary of this. And I think you would have got an idea of how and why we use the Fibroscan and University Plus. So now I think we have some time, because I, of course, am a firm believer that lectures, even to all my medical students, I don't go beyond 45 minutes, because I think our intent, concentration or attention span is very low, and if you are Gen Z, it is even less. So we will stop there, and we can ask. I'm sure there are a lot of questions which we can address. Is fibrosis of the liver, is it reversible? Yes, definitely. Not even fibrosis, that technically cirrhosis is also reversible, theoretical. So fibrosis of the liver, we have shown in our studies on thalassaemic patients, is definitely reversible. In most, it is now accepted. The first FDA approved drug for nasal was approved this year in April. It's called resmetirom, and that is available in Sri Lanka as well. It is roughly about 1,000 rupees a tablet. It's not available in the state sector as yet. But again, treatment there is dependent on the stage of fibrosis. So if it's between 2 and 3, you can use this resmetirom drug to reverse fibrosis. But the most important thing in reversing fibrosis is weight loss. So if you can lose 10%, if your body weight is 100 kilos, to lose 10 kilos, you can reverse fibrosis, right? So fibrosis is reversible. The main cornerstone is weight reduction, stopping alcohol. So alcohol, 100% you have to stop. Then let's see. What is the role of vitamin E? Yes. So vitamin E high dose, that is 400 milligrams twice a day for up to 2 years. More than 2 years, they advise not to use vitamin E high dose. So there is evidence, some evidence, and there was a trial done by Arjuna, which they showed that biopsy proven fibrosis, it is helpful, right? Again, in those patients, in a subset in diabetic patients. So high dose vitamin E, there is a place, yes. but it's not the FDA approved treatment is resmetirom. But you can use high dose vitamin E as well. We also use that. But again, it is not more effective than weight loss. So obeticholic acid, again, obeticholic acid in a Flint trial was used, and that again showed that there was some benefit. We use obeticholic acid as well. However, again, I must say it's not FDA approved. The only FDA approved drug for muscle is resmetirom. But we do use obeticholic acid as well because it's based on trial evidence. There are two trials that have shown working. One is with high dose vitamin E, the other one is obeticholic acid trial, which did show a benefit or reduction of fibrosis by using obeticholic acid and high dose vitamin E. However, the FDA assessed all that data and didn't give approval for obeticholic acid. However, resmetirom they have approved. That's the only drug at the moment approved for the treatment of muscle, and it's based on the fibrosis score. So if it's below 2, you don't use it. Between 2 to 3, F4 again it's not approved to use. So F4 you have to just do other measures. Then let's see the other questions. Ursodeoxycholic acid has no place. CQ has no place. Yes, so again to summarize, treatment of fatty liver disease or treatment of muscle, right? The number one thing is, it's very common in diabetes, look for it, because again, it's asymptomatic, you have to look for, you have to screen, you have to do ultrasound scan, you have to do LFT. Once you find it, the cornerstone is diet control. You have to get weight reduction. And so 5% weight reduction, steatosis is reversed, 10% weight reduction, fibrosis is reversed. So one of the most important effective treatments is weight loss in patients. So how you achieve that is not important. You can achieve that through diet, exercise, bariatric surgery, whatever. That doesn't matter. You have to reduce the weight. So then if you want treatment which has evidence with high dose vitamin E, 2 years, because don't go more than 2 years. Obeticholic acid, yes, there is some evidence, but both those treatments are not FDA approved. The only FDA approved treatment is resmetirom. Dose is 80 milligrams daily. Antifibrotic drug in neurofibrosis, so this is resmetirom. There are some commercial preparations out there that various things that the liver support and milk, thistle, all that. So those are, of course, you can't recommend them this thing, but black coffee that is without sugar, without milk, again has there is some evidence to help that it will help reduce muscle, but no large trials, nothing out there. So what we generally do is, ideally, of course, everyone is on weight reduction. Some, if you can afford resmetirom, yes, you can do that. But again, you have to check and see whether it is F2 fibrosis or above and less than F4. Because if it's more than, if F4 is considered cirrhosis, then there is no point in treating that patient. But you can still try for weight reduction and obeticholic acid and vitamin E high dose. But again, remember, we are living in an era of evidence-based medicine, and so this is not FDA approved treatment. As long as you discuss that with the patient, then that's okay, trying. And ursodeoxycholic acid, remember there is no evidence at all, so don't use that. Yeah, so one person asked him bacterial strain. So the only, so far, the only, uh, there are various types of strains. We used a commercial thing, which has bifidobacter, but probiotics are a big problem because you need more than, uh, I say 10 billion colony forming units, and it has to be delivered to the gut. We have to deal with live, so that's a big issue with probiotics. But at the moment, there is no evidence that probiotics work. Well, thank you very much. I hope you benefited from this. Please read up and follow the simple thing of because fatty liver. I'm sure all of you will come across that. So remember the new classification and remember to calculate FIB4 and manage it like that. Thank you.
Yes, thank you very much, sir. That was really insightful and it was excellent presentation. We think that your deep dive into this role of fibrinogen in hepatology was truly enlightening. Most of us, we had more than 200 doctors participating for today's session, and all of us got a very much deep knowledge from your expertise in this area. So once again, thank you very much for this well insightful presentation and sharing your time and wisdom with us in this Sunday morning. So, as I said, thank you very much for all the participants for today's free program as well. So now the link is available in the chat box. You can find it, and I will repost it once again as well. So kindly give us your feedback also. There is a post-assessment questions name there, so you can answer the post-assessment questions as well. You will receive your e-certificate within this week. We know we have more than 200 doctors participating today, so it will not be easy for us to send all of them today itself, but within a week we will try to send all the e-certificates for all the participatees. And thank you very much once again, sir, for giving us your knowledge, expertise, insights, and truly it was enlightening on this very deep topic that we've discussed about. One more reminder, we will have this Shri program next Sunday also. So you can join with us next Sunday as well to have a very interesting clinical topic like this that we had today. So thank you very much, sir, once again for giving us your wisdom. And thank you very much for all the doctors who participated today and hope to see all of you on next Sunday morning with another productive Shri program as well. Thank you.